We have a packed and exciting schedule ahead, so without any further ado, let's begin the first session of the day on thorax imaging. It is a great privilege to welcome our esteemed chairpersons for this session, Dr. Subha Digumarti, Associate Professor of Radiology, Mass General Research Institute, Boston, Dr. Venugopal, Consultant Pulmonologist, KMCH, and Dr. Ramesh, Senior Consultant Radiologist, JIPMER. Please join me in giving them a warm welcome. First up, to kick off our session, we have Dr. Isha Rajput, a leading voice in thoracic imaging. She will be speaking on approach to lung nodules, current guidelines. Please welcome her to the stage with a warm round of applause.
To respected chair and all the delegates who have gathered together for the first session. I am Surgeon Commander Isha Rajput. I bring you greetings from INHS Ashwini, Mumbai. And today my topic is approach to lung nodules, current guidelines. But a little digression from the main topic. This is the Indian Naval Warship INS Marmugao, where I was posted and I had the privilege and honor to serve on board for 21 months. This was the crew who were under my care for 21 months. And you can see me somewhere here. This is me. And we were 5 heads of department who were looking after the whole ship. And being the senior most on board, I was in the middle. So with that background, I have now shifted to INHS Ashwini as Associate Professor, Radiology. Ashwini is the biggest naval hospital on the western coast, 1100 bedded, and has all the tertiary care facilities. So starting with the topic today, the most important thing I feel is to simplify the tough topics. It is easier to read from the books. There are a lot of resources available online and even offline. However, the importance and benefit of a teacher who simplifies the tough topics is it's very important. So that is where I intend to pitch in. Let's start with the Fleischner Society guidelines, which are the current guidelines to deal with lung nodules. So first disclaimer, Fleischner guidelines initially started 2005, which was given for solid nodules, wherein a multidisciplinary international group of pulmonologists, radiologists, and surgeons and pathologists came together and thought of giving some guidelines how to deal with incidentally picked up pulmonary nodules. These were made in 2005, wherein the size criteria was 4 to 6 mm or less. In 2013, it came for subsolid nodules, which was a separate table altogether. However, what we follow now is the 2007 recent guidelines, which brings together solid as well as subsolid nodules. What are the implications for patient care with the Fleischner Society guidelines? The first thing and foremost, you have to remember that it is applied to incidental nodules, lung nodules which are picked up incidentally. So these have to be managed according to specific recommendations, but these guidelines do not have to be applied in patients younger than 35 years because the chances of lung cancer are much less in them, and in literature it is picked up to be less than 1%, and that is where Fleischner guidelines do not have to be applied. In immunocompromised patients or in patients with a known malignancy. So in these cases, we will not apply the Fleischner 2017 guidelines. These guidelines also give us very good measurement techniques. to obliterate completely the inter-observer variation, provided the schedule followed for sequencing and imaging remains the same over follow-up examinations. For lung cancer screening, like many hospitals are running lung cancer screening programs, in that you have to adhere to guidelines given specifically for lung cancer screening trial, which has been elucidated in LLST. There is a complete different talk on NLST. So in that, the lung cancer screening guidelines will be discussed. But today, we will adhere only to incidentally picked up lung nodules, Fleischner guidelines. So like this case, we had a cancer urinary bladder patient with multiple soft tissue nodules. Some of them were fissural based, some of them were centrilobular. So this is a random distribution of nodules which will not go under Fleischner guidelines at all. Advances in knowledge. For solid nodules, the 2017 guidelines, the minimum threshold size has been increased. Because of over a period of time, it has been found that bigger nodules need a more stronger follow-up. For subsolid nodules, a longer period is recommended. Why? Because subsolid nodules most of the time deal with or bring up in adenocarcinoma, bronchoalveolar carcinomas, which are very indolent growing lesions. They need a long period of follow-up, and that is why the period of follow-up has been increased to 5 years. So these are two tables. One is for solid nodules and the second is for subsolid nodules. Although it may look very daunting to you at this moment of time, but allow me 10 more minutes and this will all become very simple. Let's start with the first things first, how to measure, because this is the cornerstone. If you measure correctly and perfectly, you'll be able to follow the nodules better. So pure subsolid nodules, there are two methods of measurement. First is by common caliper measurement, or it is 3D nodule volumetry. By manual caliper measurement, you have to do it on 1 mm thick sections of HRCT, and you can measure it in any plane, coronal, sagittal or axial, whichever plane the nodule is largest looking. This was not there in earlier Fleischner guidelines. So it's important to understand that now we can, now we have to measure in whichever plane the nodule appears largest. You have to take the AP diameter in 2 dimensions and make the average of it, round it off to nearest millimeter. That would be the size of your nodule. If it is a part solid nodule, then you have to measure the ground glass component separately, the solid component separately. And coming to a solid nodule, it is easy measurement. So important point for measurements is manual nodule measurements, you have to do an average of long and short axis, both of which have to be obtained on the same transverse sag or coronal images wherever the nodule is seen to be largest on the same image. Nodule volumetry, if you are doing 3D nodule volumetry, you have to use the same volumetry software over follow-up examinations. And because we are subjecting the patients to multiple examinations, you must keep in mind the principle of ALARA. No more than 3 milligray should be subjected to the patient of an average height and weight. You should use dose modulation techniques and iterative reconstruction. Similar techniques should be used for all follow-up examinations. The most important 2 parameters, section thickness and the reconstruction filters, should remain constant over follow-up examinations. So it's a good idea to mention in your reports that how much of section thickness you have used. If you have used standard 1 mm sections or 0.75 mm sections, do mention that in your protocol. It is very useful for the next radiologist and even for the patient who is coming for a follow-up. So starting with a few important points, risk factors for malignancy, because in Fleischner guidelines, there are separate guidelines for patients who are at low risk of cancer and separate guidelines for patients who are at high risk, which I'll show you in the tables ahead. So that's why we have to know about risk factors for lung cancer. Starting with age, increased risks with advancing age. Every decade that is added after 35 years adds around 1% increased risk of developing lung cancer. Smoking. Smoking is the strongest risk factor. More than 30 pack a year, recent cessation or even current use is a high risk factor. For smoking, you have to know two things. One is pack years and second is smoking index. Pack years is number of packs smoked per day into number of years the patient has been smoking. Smoking index is number of cigarettes smoked per day into number of years that the patient has been smoking. So both can be used to assess the smoking risk. Any other carcinogen exposure like asbestos, radon or uranium, and family history of first degree relatives, especially siblings affected, elevates the risk. Size of the nodule. Larger nodules have higher malignancy risk. Morphology, very important. Spiculated nodules or lobulated outlines are separate independent risk factors. And upper lobe location in the lung. Next is multiplicity. In Nelson trial, it has been seen that the chances of malignancy increases from nodule 1 to nodule 4. That means if it is 1 nodule to 4 nodules, the chances of malignancy will increase. But starting from 4, 5 onwards, the malignancy chances goes on decreasing. Why? Because these nodules may be more likely to be infective or granulomatous in etiology. 6. In solid, non-solid or part solid nodules, there hasn't been much difference in gender risk according to for lung cancer, but for ground glass opacities or pure ground glass opacities, there has been an increased risk of bronchoalveolar cancer in females. Comorbidities like emphysema, fibrosis are independent risk factors, especially idiopathic pulmonary fibrosis. And in race, black men and native Hawaiian men have been found to have an increased risk factor of lung cancer. To consolidate all together, ACCP has given us a risk factor guidelines that a patient of young age who doesn't smoke, with smaller nodule, any other location than the upper lobe with nice regular margins are obviously low risk patients. However, if any of these criteria gets ticked, then the patient becomes a high-risk patient for lung cancer. Next, on follow-up examinations, it's very important to know about volume doubling time. For solid cancers, it is easy to calculate, 26% increase in diameter. But as I have told you, indolent adenocarcinomas can have a long range of indolent growth of the order of 3 to 5 years. For this reason, longer initial follow-up has been recommended. So now I am starting with the Fischler guidelines in the background of how do we measure the nodule size and what are the risk factors that you should keep in mind before starting to put the patient in one of these tables. So single solid nodule, less than 6 mm in size, a low risk patient, nothing much has to be done. But for a high risk patient, you can do an optional CT at 12 months. If the patient has some other high risk categories like the upper lobe location, or there is a persistence concern. 6 to 8 mm nodules, low risk, do a 6 to 12 months CT, and even at high risk, you can repeat at 18 to 24 months. That means 3 CTs at least for high risk patients of nodules 6 to 8 mm. More than 8 mm nodules, 3 months CT, or this has to be rigorously followed up with PET CT, biopsy or resection. So this was about single solid nodule. Coming to multiple solid nodules. If this is a low risk patient and they are all the nodules are less than 6 mm, no routine follow-up is recommended. But if the patient is a high risk patient, ticks any of the criteria in high risk, you have to do an optional CT at 12 months. Any of the nodule, if size is more than 6 mm, do a CT at 3 to 6 months and repeat at 18 to 24 months, keeping the most suspicious nodule in your mind. Coming to subsolid nodules, pure ground glass or part solid. For the pure ground glass nodules, there is no solid component. How much time do I have left? I think this timer was for the proffered papers presentation.
2 more minutes are there.
2 more minutes. Okay. Right. Then I would request the audience to give me at least 3 minutes more and I'll try and finish this. Okay, so for pure ground glass nodules, if they are multiple and all are less than 6 mm, you would repeat a CT at 3 to 6 months to see if they are persistent. Coming to part solid nodules, for single nodules less than 6 mm, no routine follow-up required. However, if the nodule is more than 6 mm or the solid component is less than 6 mm, do a CT at 3 to 6 months and annual for at least 5 years. Single solid component more than 6 mm, rigorous follow-up required. However, if there are multiple subsolid nodules all less than 6 mm, consider at CT at 3 to 6 months and again at 2 and 4 years. And if any of them is more than 6 mm, use the most suspicious nodule to guide your further management. Coming to special management scenarios, if they are periphyseal, subpleural or juxtapleural nodules, they are usually intrapulmonary lymph nodes, so nothing much to be done for them. Apical or subpleural scarring if seen, then it is recognized as benign. And if the patient is less than 35 years or immunocompromised, you have to manage the patient according to a specific patient case. So this is a diagram showing typical periphyseal nodules which are oriented along the long axis of the fissure. If they are nodules which are crossing the fissure or round looking or make acute angles with the fissure, then this is not a periphyseal nodule. So an example, a very typical periphyseal nodule long axis oriented along the fissure, and a typical non-periphyseal nodule. Nodules incidentally seen outside the chest, if they are less than 6 mm, no follow-up is recommended. But if there are 6 to 8 mm nodules, you have to complete a thoracic CT at 3 to 12 months for confirmation. Partial thoracic scans. Can I follow the nodule with only doing a specific limited scan? No, because it is not recommended, because new findings in the lungs can be missed and partial thoracic scans are not recommended for follow-up. So there are image vignettes here. Should I continue or stop? Your wish. Give me 3 more minutes. I'll finish. Okay, right. So specific nodule, simple, benign looking, with a calcification in between and some amount of fat on the soft tissue window, then it is consistent with a hamartoma. Leave them aside, nothing to be done. Benign calcification, central calcification or laminar calcification, incidentally detected, nothing to be done. Another case in axial section, you can see a nodule-like opacity. However, you do a coronal reformat and you find that the nodule is completely long axis oriented along the fissure. It's an intrapulmonary lymph node, nothing to be done. A similar case in the upper lobe, also, in the anterior section. Now we go to some suspicious morphologies. A spiculated nodule in the left upper lobe, definitely consistent with a high-risk case, and surgery revealed invasive adeno. Now sometimes we see small cyst-like structures located near the walls and we think that these are very benign and indolent, let's leave them apart. But on follow-up you see that the wall has thickened and now it is showing some enhancement if you do a contrast. So this must be followed up at least 3 to 6 months follow-up. This is a case of progression where the nodule has consistently increased in size, as well as in the last image you can see that it has also developed a partial solid component. Again a case of progression, increase of partial solid component, and in the second set of images there was a ground glass part solid nodule in the left side. Now a new one has come on follow-up on the right side as well. So these are both cases of progression. Few cases of resolution, complete disappearance of ground glass opacity on a 3-month follow-up shows that this was initially a benign case and nothing much has to be done.
Ma'am,
Yes,
can you summarize your final slide, ma'am?
Yes, this is the last slide. The key updates in 2017 guidelines is that the minimum size for routine follow-up has increased now to 6 mm, as I have just mentioned. Management tables have been consolidated for solid and subsolid nodules. Wider follow-up intervals have been given and measurement techniques have been elucidated. There is more emphasis on shared decision making between clinicians, radiologists and pulmonologists. So to conclude, these are a very good guidelines if robustly followed and should not be applied in less than 35 years, cancer patient, immunocompromised. These are for incidentally detected lung nodules. These are my references. Thank you so much.
Thank you, Dr. Rajput, for the truly comprehensive presentation. Your expertise in navigating the complexities of current guidelines is immensely valuable to us all. Thank you, ma'am. Next, I am delighted to invite on stage Dr. Aravind Chaturvedi, a respected authority in our field, to deliver his take on staging of lung cancer, what the radiologist should know.
Thank you very much, and thank you, chairpersons. A very good morning to all of you in the audience. I'm really happy to see the hall is almost full on a Saturday morning. I bring you greetings from Rajiv Gandhi Cancer Institute and Research Center, which is a tertiary care cancer hospital in North Delhi. My talk is on lung cancer, staging, and what we should know. There have been changes which have been ongoing every few years. These are my credentials. Now I'm Chair Emeritus and a board member of the hospital. So during the next 18 minutes or so, I'll be talking about the TNM and the stage. I would like to make a distinction between the two. The two are different. TNM is not the same as the stage of cancer. I'll also talk about the changes that have taken place in the 9th edition, which has come into force this very year. Towards the end of my talk, I'll also talk about the emerging concepts and the future directions. For a moment, let me take you back in history. The year 1944. And there was a paper which was published, Tumor, Node, and Metastasis. Now that was the very first time when the concept of tumor, node, and metastasis, or the concept of TNM, was given by none other than Pierre Donay, a French surgeon. Pierre is the same as Peter. In French they call Pierre, in English it is Peter. He was the director of Institut Gustave Roussy, which is a well-known cancer hospital in Paris, and also the president of UICC. As we all know, that as doctors and physicians, we like to differ with the other doctors and physicians. And so at that point in time, the Americans had a different system, and the Europeans had a different system. He represented Europe, and the Americans, what they followed was the AJCC, and the Europeans followed the UICC. It wasn't until 1986 that another thoracic surgeon from MD Anderson Cancer Center united the two processes, the Americans and the Europeans, and he unified the lung cancer staging system. So now both the systems work together, that is UICC and AJCC, and they have the same TNM classification and the staging system. Now coming back to TNM. TNM is nothing but a measure of the anatomic disease extent. How much is the disease? What is the size of the tumor? How many nodes? Are there metastases? So this is in simple terms quantifying cancer. And TNM leads to the stage. TNM gives an idea as to what stage the cancer is, which is something different. I'll clarify that. So here is the TNM, and that will tell you, you have to calculate what T, what N, what M, and what stage it is. So there is a chart, and in this chart, this is the 9th edition. If you look at the T, see the N, and the M, match it with the M, you'll get the stage. You don't have to remember it. It's good to have the chart handy, and it will keep changing every few years. So don't try to remember, because cancer staging will change every few years because there are new developments in science. Why does it change? Why the TNM staging keeps changing? It's a very dynamic process. The 7th edition was in 2020, the 8th edition in 2017, and now we are in the 9th edition. In January 2025, it has been adopted. The reason why it keeps changing is because there are new treatments, new information, advancements in science. So what we initially thought, that the two patients were in the same stage and the outcome will be similar, the outcomes changes. And if the outcome changes, we have to categorize them into different stages, and that is why we have to keep revising the TNM staging as well as the staging system every few years. Who does it? Whose responsibility is it to change the TNM or the staging system for lung cancers? There is a Lung Cancer Staging and Prognostication Factors Committee, which is a part of the International Association for Study of Lung Cancer. And they collect a lot of data, and everything is based on the data. For the 9th edition, the data has been collected from January 2011 to December 2019. We are in 25. Why not beyond that? Because you need that much time for the data to mature. You need to follow up the patients. And this data has been collected for 25 countries from 75 different sites. One of the drawbacks of the previous editions of TNM have been that the vast majority of the data was only confined to North America. Now, for the 9th edition, 56% of the data is from outside of North America, from Asia and Australia. So this is more representative of the world. As I mentioned, survival data is the basis of TNM revisions. I won't go into the details of this crowded slide, but with minor differences in the T size, there have been different survivals. And this is the clinical stage survival curves, and this is from the pathological stage survival curves. So if the survival differs, you observe that the survival is different, you need to reclassify, rethink about the TNM. Why these two patients whom we thought were the same stage are behaving differently? Because there are some subtle differences between them. And that is why the staging system will always be changing every few years. Talking of the 9th edition, the key changes I'll mention. I will not go into the details of all the T, N, and M classifications, but the key changes have been in the N stage. N2, you know that N2 is ipsilateral mediastinal lymph node. Now N2 has been divided into two, N2A and N2B. This is one key change now that we follow in 2025. N2A is a single N2 station involvement. Mediastinum has multiple stations, and so if it's only a single station where lymph nodes are involved, it is N2A, and if there are multiple stations, it is N2B. Another big change has been in the M1C stage. M1C is C1. M1C1 is multiple extrathoracic metastasis in a single organ. I just want to clarify here that if there are multiple bony metastases, it is a single organ. It's a single organ system. It's not that there are multiple sites and you'll call it M1C2. But if there are multiple extrathoracic metastases in multiple organs, for instance, the liver and the bones, it becomes M1C2. So remember, M1C has been divided into M1C1 and M1C2. These will be just a few quick examples. T1, as we know, is anything less than 3 centimeters, but T1A is less than 1 centimeter, and T1B is between 1 to 2 centimeters. So if it is 1.9 centimeters, it becomes T1B. T2 we know is 3 to 5, T2A is 3 to 4, and T2B is 4 to 5. This lesion is 3.5 centimeters, so it becomes T2A. So once you have all this data, you can actually go to the stage. But what came up in the 8th edition itself is that every centimeter counts. Increase in size of the lung cancer, even by a centimeter, puts it in a different T category and maybe a different stage. So it matters. Another example, a big cancer here with mediastinal invasion. So obviously it is T4. But we also see a pleural effusion. And pleural effusion, if it is positive, we know that it is M1A. And M1A makes it stage 4A. If you look at M1A, and everything is 4A. So it's good to keep a chart handy and then fill in all the blanks there as to what T, what N, what M, and you get the stage. As far as the end stage is concerned, I had already mentioned in the ipsilateral lung up to hilar it is N1, but N2 is ipsilateral mediastinal. And if it is one station, subcarinal, here you can see it is N2A. And if there are multiple stations, right paratracheal and subcarinal, then it is N2B. N3 is contralateral, contralateral mediastinal or a supraclavicular or contralateral supraclavicular. I just want to highlight here that as far as the level 2 and level 4 nodes are concerned, it's not a midline. It's not a midline. It is the left border of the trachea up to which the lymph nodes will be considered as right-sided and anything beyond that will be considered as left-sided. That is how the lymphatic drainage works. And so right up to the left border of the trachea, all these nodes are considered to be right-sided. Level 2 and level 4. Just an example, PET CT scan, that's the lung cancer, and there is a node contralateral supraclavicular that will make it not metastatic, it will be N3. We have already talked about this. The big change in TNM about the metastatic staging is that M1C has been divided into M1C1 and M1C2 based on the different survival of patients who have multiple metastases in a single organ or multiple metastases in multiple organs. Now, we have to pause and go beyond TNM. I mentioned in the beginning that TNM is quantification of cancer. You are only measuring the anatomic extent, but is that all you need to know? With advances in science, you need information beyond the histology and beyond the TNM. There is something known as the genomic signature of the cancer. It doesn't apply just to lung cancer. It applies to breast cancer, colon cancer, name any cancer. The oncologist today wants the molecular profile. And the treatment is based on that. The outcome and the prognosis is also based on that. Every cancer has its own genomic signature, and biomarkers beyond TNM have become very, very relevant. Talking of lung cancer, we all dealt with histology, different types of histology, small cell, non-small cell, in small cell, different types, adenocarcinomas in non-small cells, squamous cells, so on. But within that cancer, depending on what kind of mutations are present, the survival is different. Everybody knows about EGFR. You talk of a lung cancer, the oncologist doesn't want just the histology. He says, okay, EGFR status, KRAS, mutant or not. Because if EGFR is mutant, those patients do much better because there are targeted drugs. If EGFR is wild type, they won't do as well. Similarly, there are differences between KRAS mutation and EGFR mutation. Now there are drugs against KRAS as well, but KRAS doesn't do as well as the EGFR mutations. So the molecular signature of all cancers, particularly lung cancer, that is the topic today, has become very, very relevant. And now the same International Association for Study of Lung Cancer wants a molecular database. It is already there. but the data was not mature enough to make changes in the 9th edition. Be rest assured, in the 10th edition, you'll be talking of much more than just TNM to stage the cancer. All the molecular data sets will be incorporated in future staging systems. And as I'm repeating, that lung cancer has a genomic and proteomic disease it is with multiple subsets. And simple example is of stage 4 ALK mutated non-small cell lung cancer when it is treated with alectinib, which is the targeted drug, has a 5-year survival of 62%. Stage 4 lung cancer, 62% survival just because of one target available for a particular drug to act. Dr. Isha Rajput mentioned about lung nodules, a very good talk. In fact, Surgeon Commander Isha Rajput, she's from the Indian Navy. So talking of lung nodules, very often you see multiple lung nodules. Are these lung nodules in a case of cancer, are they metastasis or they are multiple primary lung cancers? The concept of multiple primary lung cancers is evolving. In fact, they are much more than what we think. We just label them as metastasis. In the case of lung cancer, they may not be. It's very important to draw that distinction for the simple reason that the multiple primary lung cancers will have a much better prognosis as compared to if they are metastasis. So if that is the primary, all these other nodules, are they different primaries, including another primary in the opposite lung? Or are they metastatic? There are different ways to kind of understand and to come to a conclusion. It is not foolproof as yet. If their molecular profile is identical, and if there are no mediastinal lymph nodes, then all of them are multiple primaries. And they can be treated as such. And it can be, in this situation, a T2A. You mentioned the number of nodules, 5, N0, M0. But if they are different, it could be metastasis. I need to correct myself here. If it is same molecular profile, then it is metastasis. And if they are different, the molecular profile is different and no mediastinal lymph nodes, then they are all primary lung cancers, and a more aggressive approach is required to address. So there's a lot of talk towards the molecular era of discriminating multiple lung cancers. You biopsy both and see the molecular profile. If it matches, it is most likely metastasis. And then you might also find, if it's in the opposite lung, some mediastinal lymph node involvement. If there's no mediastinal lymph node involvement and their molecular profile is slightly different, then there are two different cancers. An aggressive approach is required for those multiple primary lung cancers. So where are we now in the future? What are we going to do? Cancers, ladies and gentlemen, will be grouped on the basis of molecular profile and genomic signatures in addition to the TNM. TNM will be a small component of overall classification of all cancers. Today, if we talk of T2N1 M0 in case of lung cancer, maybe in the future, we'll be talking of T2N1 M0 is fine, but we have to qualify EGFR mutant. This is 19 deletion, exon 19 deletion. What is the status of circulating tumor cells? Is it PDL positive, PDL1 positive or negative, or what percent? So all these qualifications will be required before you reach a conclusion to tell the actual stage or the actual prognosis of a lung cancer patient. Prognosis of the patient depends not just on TNM. There are multiple variables, and these variables can be tumor-based, host-based, or environment-based. As far as the tumor is concerned, we have talked about the TNM at length. And we have also talked about the EGFR, KRAS, and PDL, etc. So they are all tumor-based. Then the residual tumor status of after neoadjuvant systemic therapy. If it has responded very well to systemic therapy, those patients will do much better. At the same time, presence of brain metastasis makes the disease far more worse. As far as the host is concerned, the performance status of the patient. A poor performance status with multiple comorbidities, that patient with the same stage is not going to do as well. So there are multiple factors. And then there are the environmental factors. Imagine a patient in a rural village in the state of Tamil Nadu. That patient with lung cancer, even if it shows a favorable prognosis, will not survive that long. He has no access to tertiary care hospitals. So access to care, the socioeconomic status, your ability to afford the treatment, everything matters. Thank you very much. I have come to the end of my talk. All I want to say to conclude is that we are moving towards personalized staging system. Everybody is different. You show me the individual, it is not just the TNM, but I will have to look into the molecular profile and many other factors before I say how this patient is going to do. Thank you once again.
What a captivating and insightful session. The way you broke down such complex information was incredibly clear and made this material so accessible. We thank you, Dr. Chaturvedi, for sharing your invaluable expertise with us. Thank you, sir. The delegates are requested to raise the queries through the SOIICON app or the QR code which is displayed on the screen to raise the queries. No verbal queries will be encouraged in the session. To all the presenters, a beep during a presentation will signify that you have 2 more minutes left. Next up, we have a case-based discussion on lung cancer mimickers. Unfortunately, due to unavoidable circumstances, Dr. Poonam Sherwani could not be here. On behalf of her, Dr. Isha Rajput will be presenting the paper.
Right, so the timer is my friend now. It has already spoken so many times that now it will be shant for some time. Right. Good morning, everyone, once again. And here I am. This is a presentation by Dr. Poonam Sherwani, Additional Professor, AIIMS Rishikesh. Ma'am could not be here due to unavoidable circumstances. So I bring you the shared knowledge from AIIMS Rishikesh. Lung cancer is the 3rd most frequent site of malignancy and the commonest cancer in the world. And there are multiple non-malignant lesions which can mimic lung malignancy. That's why a thorough medical history, lab diagnostic workup, as well as careful analysis of imaging findings help us in arrival at the final diagnosis. Of course, image-guided sampling is currently the gold standard along with the histopathological examination and molecular genotyping of the cancer. One important point I would like to drill home to all the PG students, whenever you are doing oncoimaging reporting, whether it is the first time that the patient has come to you or he is on a follow-up after a previous radiotherapy or chemotherapy and now restaging has been requested, always ask for previous documents. If the patient has had a surgery, the scan before the surgery, the scan after the surgery, the scan after chemotherapy, and the most recent scan. You should have all of them on your consoles. Do not trust anybody if they say that you don't have a scan. Reach out to the previous college or hospital and do get hold of those scans. Those are a gold mine of information, and without them, your reporting will be incomplete. So there are multiple lesions which can mimic lung cancer, which range from a whole plethora of infective, inflammatory and benign etiologies, as well as sometimes congenital lesions in younger population. So there are 8 cases here. First case, a 67-year-old male who was an ex-smoker and presented with dyspnea cough with mucoid expectoration and streaky hemoptysis, a history of pulmonary TB which was treated but incompletely. So these are the scans that are available with us. We see a large heterogeneously enhancing soft tissue mass lesion in the right upper lobe. I can't find the marker. Okay, it's there. Right. Thank you, sir. Right. So it's in the right upper lobe. You can see this lesion. Yeah. Okay. Now the arrow marker is not that friendly to me, but I'll make friends again. Fine. We have the lung windows also, which are showing the similar opacity in the right upper lobe, and it is showing spiculated margins as well. Definitely it becomes very suspicious in the mind of anybody who is looking at any patient who is a little 35 to 40 years, history of smoking, incomplete pulmonary TB treated, but still you have that aura of malignancy at the back of your mind, and you think that this lesion might be suspicious. Coronal reformats also show us that the lesion is quite spiculated, and similar coronal reformats in lung windows. The biopsy revealed necrotizing granulomatous inflammation, and which was negative for malignancy. And from BAL, CBNAT was done, and this was confirmed to be MTB. Now, with a history of incomplete ATT, you would think of drug resistance, but this was not. So the first case was tuberculoma, or a large lesion which was spiculated margins. However, tuberculomas, in usual rut of the cases, these are well-defined round to oval focus of pulmonary TB, which mimic lung cancer. They sometimes show calcification, cavitation, or satellite nodules, and variable contrast enhancement is the rule. The second case, a 61-year-old male, a reformed smoker. Again, reformed smoker, this history is coming in again and again. So as in my first talk I have mentioned you, smoking is a high risk criteria for all incidentally picked up lung nodules also, according to the Fleischner guidelines. So it's very important, when you are taking history, always ask for age of the patient, history of smoking. If the patient says I have stopped smoking, do make it a point to ask that when did you stop? Yeah, last night? And how much have you smoked over the years? So smoking index is number of cigarettes smoked per day into number of years you have smoked, and pack years is number of packet of cigarettes smoked per day into number of years. He was a daily wage laborer by occupation, no comorbidities in the past, with no other contributory history. And there were large lesions on the radiograph, well-defined intrapulmonary large lung masses in both the mid and lower zones in both lung fields. There's a smaller lesion in the left upper lobe as well, which is also showing a little bit of spiculated margins as well. The larger ones are easy to pick up. It is the importance of good radiologists lies in picking up more smaller findings. Right, so we have soft tissue and lung windows, which is showing relatively homogeneous lesions which have been randomly distributed in both lung fields. Many of them are pleural based with obtuse as well as acute margins. And this was biopsied, and what did it reveal? This was, can you see? There was no malignancy, but there were chronic inflammatory cells within the lesion. What was this? On histopath came out to be pulmonary hyalinizing granuloma. This is a differential which I would not have thought of if I saw this X-ray. On X-ray it was looking like cannonball mets. Many of you would agree with me. So what is pulmonary hyalinizing granuloma? A rare condition which presents as solitary or multiple nodules. Fibrosing nodules consist of central whorl deposits of lamellar collagen. These are benign lesions but can grow to a large size and then cause a very vivid presentation, just like the radiograph that we saw. Solitary lesions are rare. This is important to note that the solitary lesions are rare. They are usually multiple and go together. They can grow or be stable or regress. They can be associated with other infections like fungal or mycobacterial, and even sarcoidosis and other kind of granulomatous diseases may coexist. The third case, a 4-year-old female child presented with recurrent pneumonia for 4 months duration, cough which increased on lying down position, no history of fever. On examination, there was decreased air entry on right side, with few crepitations. Now these kind of radiographs are very important for postgraduates. First things you would think that this is increased opacity in the complete right hemithorax. However, you must look at this lucency in the lower zones. This shows that this is probably not just a plain pleural effusion or increased opacity in the hemithorax, and there is something sinister sitting inside. Ultrasound was done and there was found to be a mass lesion which along with the collapse of the right lung. On the CT also there was a mass lesion which was causing obstruction of the right bronchus as well as the right pulmonary artery as well. On the contrast images you can see. The biopsy was done for this patient and it reveals spindle cell lesion infiltrating the lung parenchyma, and final diagnosis was inflammatory myofibroblastic tumor. This is one differential that should be entertained in cases of pediatric population. However, it can very rarely it is seen in adults but commonly seen in children only. Presence with cough, fever, chest pain and hemoptysis, and etiology is mostly unknown. Recurrence and local invasion are common, and that's why these children are put on follow-up even after treatment. Case 4, a 31-year-old male who presented with generalized weakness, fever, cough and sputum for 3 months. So one look at the CT images and you can see that few very daunting findings. Okay, yeah. So here we have in the right hilar, there is a mass lesion or lymph nodes with chunky calcification. You can also see bilateral pleural effusion. There are few areas of projections in the right lower lobe which are enhancing, and similar nodules which are randomly based and randomly placed are seen in the lung window as well. So what would you think if you saw such a picture? It is difficult to think when you are sitting so many of you in the hall together. But when you are alone on the console, it is you who are making the decision, and all this training is for that only. Biopsy and histopathology revealed that this patient had necrotizing granulomatous inflammation, tuberculosis, stain for AFB was done and report with follow. But there are multiple causes of pleural calcification, and this case was to show you one of them, which was tuberculosis. However, empyema healed, asbestosis, mesothelioma and pleural mets, all of them can cause calcification, and lymph node chunky calcifications, you must always think about TB, sarcoidosis, Castleman's disease to be the first 3 differentials. Case 5, a 15-year-old male presented with hemoptysis. 15-year-old, relatively adolescent population, and in our country, many of you must have guessed this already. So what can you see? In the lung windows, you are able to see a large lesion, nodule, large mass lesion in the left upper lobe, likely in the lingular segment, which is showing heterogeneous attenuation. On the right side, there is pleural effusion, and along with that, on the lower cuts in the CT, you can see that there is a large liver abscess present. Along with that, there is an air fluid level in the right lung as well. So here we have a very common ineffective condition in Indian population, that is hydatid cyst. Complicated and atypical forms may be confused and can mimic lung malignancy and appear as a lung nodule or a lung mass. It is caused by echinococcus. All of us of course know that, but these patients sometimes may not give a typical history. So it's always good to, when you are seeing lung nodules in the chest or a lung abscess, air fluid level, do a little bit of liver, or in the scan include the liver, or second option is do an ultrasound if the patient is available to you. Whenever the patient is in your department, make an effort to do as many investigations as are available to you for those who are in government medical colleges and the patient is not paying for each of them. It is all the resources are at your hand. So make an effort, go meet the patient, take history, make an effort to do an ultrasound at the same time if you see some lesion on the CT. Makes your life so simple. Case 6, 33-year-old male known case of silicosis who presented with fever, decreased saturation and sepsis. And this is a no ticketer, no high ticketer, because all of you can see these large consolidating masses, most of them directed towards the hila, mass forming. So in a known case of silicosis, you would definitely think of lung. On the lung windows, you can also see large fibrosing lesions in the periphery, which are all kind of accumulating towards the hila and getting pulled towards the hila. So this is another reformat, progressive pulmonary fibrosis. Very common in cases of long time exposure. So I do have 2 minutes more and I'll finish this in time. That's a promise. So classical occupational exposure to inciting factors can occur. Asbestosis, silicosis very commonly do develop to progressive massive fibrosis over a period of time. Patient will have constitutional symptoms, fever, cough, hemoptysis, raised TLC. Right, 7th case, a 33-year-old male with dry cough, flu and weight loss. Multiple nodules were seen, some of them were pleural based on the lung. And what could be seen on lung windows that these nodules looked very well defined on the soft tissue windows, but when you went through to the lung windows, you saw that there is a lot of ground glass attenuation that was associated with the nodules, and most of them were peripherally based with some amount of consolidation as well. So this was a case of organizing pneumonia. Acute cases, when they come to you, you have multiple consolidations, pleural based, peripheral in the lung, some of them with ground glass, much more ground glass on lung windows as compared to soft tissue windows. Always think of organizing pneumonia. Last case. So this is a lesion which is on soft tissue window. You can see that there is a well-defined mass lesion, not so well-defined actually. And on the lung windows, you can see that there is a very prominent air crescent sign which is seen. So air crescent sign, if you see from all our PG days, we have been trained to think of aspergilloma, and that's what it was. 4 types are known: invasive, airway, semi-invasive and aspergilloma. Aspergilloma is when fungal hyphae home on to a pre-existing cavity like tuberculosis or old lung cancer treated or scarred tissue. And it shows air crescent or monad sign. So the take home message is lung cancer is very common, but it has a range of mimics, and you should know the history, the workup as well as imaging findings to come on to a right diagnosis. These are the references that have been used. Thank you so much.
That was a very practical and eye-opening approach to imaging lung cancer mimickers. You have given us an expert perspective to approach such challenging cases. Thank you, ma'am. I would now like to open up the floor for a brief discussion of queries.
That was a nice talk by both speakers. The thing is, being a pulmonologist on the other end, like it will be very easy to say that biopsy the lesion. So biopsy the lesion will be like whatever the nodules. So the problem here is in an Indian Asian subcontinent, like whatever the literature or guidelines, what we see is from the Western population, where we are more keen towards to rule out malignancy, not to miss malignancy, not to miss malignancy. Here, most of the times the nodules, that too with the advent of the COVID era, the more and more CT era, we pick lot of nodules. These nodules, really in the real-time scenario, how much those are benign and how much those are malignant, this is the question that needs to be addressed at the Indian subcontinent. But to do that, we don't have the resource of the same scale all over the Indian continent. So that is one problem. The expertise, like you don't have a good radial studio, CT guided biopsy, or a radial EBUS, or a virtual navigation platform, or a robotic bronchoscopy, or a good thoracic surgeon to take a nodule out of it. So this is a huge. So I think at least we do have some at least zonal reference for, in the future for the radiology, and more dissertation on the nodules from the radiologist side, and collaboration with the pulmonologist will be, I think it's my thoughts for the future of the, we do have some Indian subcontinent guidelines, and it was a very nice talk from both sides. Thanks for it.
Thank you very much. It was a excellent talks. And to address the question from Dr. Venugopal, by the way, I am Subhati Gumarti. I practice in Boston at Mass General Hospital, but I did pursue my education in India for a long time. So to answer your question, you have to take the characteristics of the prevalence of lung nodules based on the endemic area. So in US, there are some areas which are in the Mississippi belt where histoplasmosis is very prevalent, and areas where coccidioidomycosis is very prevalent. So there the radiologists are more aware. They don't say that follow the guidelines as loosely as we follow elsewhere where those conditions are not endemic. In India, where tuberculosis is very endemic, most of the nodules are not to be related to tuberculosis one way or other, which is a very valid point. So we should not waste the resources by trying to pursue these nodules and do repeat imaging. In US, the tendency is to follow these nodules, establish the stability, but then most of the population in US, they are insured, so they don't have to pay out of pocket. But Indian subcontinent, the context is different. It's a huge resource draining exercise for the patients just to do a follow-up purchase CT scan for 2 years. That's very expensive. So I agree with you. There should be a methodology which should be unique to India to reduce the cost. One thing that would be useful is to use radiomics. So there's a lot of research going on in AI based on the endemicity, endemic area, the prevalence of the lung nodules which are related to granulomatous diseases. We can estimate the risk of that being a cancer. So that is very useful. And other thing is, in India, women do not smoke. So whereas in US and Western cultures, the smoking is very prevalent even among women. So here, because the smoking is so less common in women, we can actually downplay the risk of the lung nodules. We don't have to really follow the Fleischner guidelines, which is mostly for Western societies. So that is something which will be very useful for Indian context.
With your permission, just a very brief comment. And this is about the prevalence of tuberculosis in Asian countries and particularly in India. Many years back, we did a study, and there were many patients from this TB hospital in Delhi, RBTB hospital, who were not showing response to anti-tubercular treatment. They were established patients of tuberculosis. And it was considered as multi-drug resistance. We ended up doing a study and we biopsied many of those nodules, and there was cancer coexisting with tuberculosis. And the cancer was spreading, and TB may have been controlled to some extent, and it was mimicking as multi-drug resistance. The point I'm trying to make is that don't dismiss all TB if they're not responding as multi-drug resistance. There may be a cancer hiding there. And this will apply to all other granulomatous diseases as well.
Thank you very much. That's a very valid point.
Here, sir, I would just like to make one small suggestion that many of we as radiologists, we are scared that if we do a guided biopsy, ultrasound guided or CT guided, it will cause pneumothorax. What if pneumothorax happens? What will we do? So this is for your question only, sir, that it's easier to say than do the CT guided or ultrasound guided biopsy. But therein lies the liaison between radiologists and pulmonologists in your hospital. Many a times when I'm doing biopsies, I do request a resident or even my pulmonologist. Of course, he is junior in service to me, so he comes. But that's another story. You can ask your residents, colleagues in other departments to help you out if you're doing a procedure for the benefit of the patient. And you must try and master the art of putting a chest tube. All of us are MBBS first, so putting a chest tube for pneumothorax shouldn't be difficult. Do try it. Give it a shot at least. Ultrasound guided chest biopsies for pleural based nodules, it's not difficult. And for lung nodules which are deep seated, yes, you do need a CT guided biopsy and the whole setup along with that. So that is where I suggest.
Being the pulmonologist, what I will say now, that any procedure that needs a high risk of malignancy or something like that, nodule needs to be biopsied, that needs to be biopsied. Pneumothorax should not be considered as a complication. Suppose you want to get a good tissue, I'm not telling you the thing. Suppose you want to give it to a surgeon, what they will do? They will do a VATS and think they will put a chest drain. I will take as a complication failure to recognize pneumothorax. Is the complication, is the negligence, but pneumothorax, whatever, you do a CT and you look for a repeat CT or whatever thing after 2 hours and you put a high flow water at drain. So failure to pick up the pneumothorax is a complication. Pneumothorax, whatever the 5% or whatever the risks at times, not everybody will be having an access to radiolibus or a quant beam CT. That access we have at KMCH. So it's something like we have to what the resources we have, what the patient benefit you have, and the subset, if it is demanding a biopsy, that has to be done. So failure to recognize will be, I consider as a complication rather than a pneumothorax.
That brings us to the end of our discussion. We thank you all for this engaging session. We thank the chairpersons, Dr. Subha Digumurthy, Dr. Venugopal, and Dr. Ramesh. Thank you, sirs. Next upon, we have a urology session pre-pon. I'd like to welcome our speaker, Dr. Deva Senadipati, Professor, AIIMS, Delhi, on stage for a presentation on what urologists need to know, the crucial role of imaging in renal cell carcinoma.
Thank you so much for the introduction and the invitation to this conference. And initially my session was slotted on GUT session, but I didn't have guts to present in there, so took refuge into this session, and thanks for the organizer to slot me in this particular session, so I had to leave early, so that's the reason. Okay, so in the next 20 minutes or so, I'll talk about the imaging valuation of renal masses, especially with more stressed more on the RCC part and some mimics of RCC and other nephrometry scores if I have time. So renal focal lesions are very common. Most of them are, they are cysts. Most of them are simple cysts. You don't have to worry about them. Just you can easily recognize them on ultrasound itself, and they are not worrisome lesions. The problem occurs when you are dealing with solid lesions. That's when the characterization is very important. And imaging is good, but sometimes you end up saying these are indeterminate lesions and difficult to characterize. And there are mimickers like AML and papillary oncocytomas, papillary carcinomas that can mimic each other, so it's very difficult to characterize all the lesions. So role of imaging here is to detect the lesion, which is the easiest part when the imaging is concerned. Characterization is little tougher when you want to characterize whether it is a malignant lesion or a benign lesion, especially knowing the fact that 60% of nodules around 3 centimeters are malignant, the rest 40% can be indolent or benign lesions. So that is a proportion. So that's a difficult part when you want to characterize whether it is benign or malignant. Even more it is tougher if you want to characterize whether even within the malignancy, whether it is clear cell carcinoma, clear cell type of RCC or papillary type of RCC or chromophobe. That's even more difficult. It is also important to follow up those lesions, whether you are picking up a cyst, Bosniak 1, 2 or 2.2F, you have to follow up under ultrasound or CT. CT is the recommended modality, but you can also use ultrasound sometimes. And it is also helpful in treatment response and to figure out whether there is any post-treatment change or recurrence or residual in a patient who was treated for renal cell carcinoma. So these are the imaging techniques we have. You all know that these are the 3 prime modalities we have. Ultrasound is mainly a screening modality. Multiphase CT is a modality of choice. That's a workhorse modality we have. That is the modality where you will invest when you are trying to evaluate a renal lesion. MR is mostly used as a problem solving tool. There are situations where MR scores over CT. We'll see few examples of that in the future slides. And few basic things I want to convey here is that when you are doing a CT, if the enhancement is, only if the enhancement is more than 20 HU, if we compare it with the non-contrast CT, that particular lesion, you can say that it is enhancing or a solid lesion, which is significant. Any enhancement less than 20 HU, if you compare it with the pre-contrast scan, is not significant. If it is between 0 to 10, it is a benign lesion because there is no enhancement. That must be a cyst which is hypertense or it's not enhancing. 10 to 20 is indeterminate. So unless there is 20% 20 HU increase in the attenuation compared to the pre-contrast scan, they are not considered as neoplastic lesions. In MR, the criteria is a little bit different. 15% increase in the signal intensity if we compare it to the pre-contrast scan. This is on MR and this is on CT. And on CT, if a lesion is homogeneous, hypodense, with attenuation is somewhere between minus 10 to 20 HU, they can be safely labeled as benign cysts because there are no septations, there are no enhancement, there is no heterogeneity, they are homogeneous, and they can be labeled as benign cysts. If the attenuation is less than minus 10 HU, which means that there is gross fat within the lesion, in which case AML is angiomyolipoma is the diagnosis which will encourage. The third thing is, if on non-contrast CT, the lesion is homogeneous, hyperdense, with the attenuation more than 70 Hounsfield units, then you should think of hemorrhagic benign cyst which has shown bleed, and that's hyperdensity because of the bleed within the lesion. So these are the general basic things that you should know when you are dealing with focal renal lesions. Few points about ultrasound. Ultrasound is very good in figuring out whether the lesion is arising from the kidney, whether it is solid or cystic. If it is solid or cystic lesion, you can say that whether it then is septate or septation is thick, nodularity is there, mural nodularity is there. All these can be picked up on ultrasound, and again it depends on the habitus of the patient. If the window is not great and if the patient is obese, it's difficult sometimes to differentiate a cystic lesion from a hypoechoic lesion on ultrasound. So that's the problem with ultrasound, but broadly you can figure out all these things on ultrasound. Simple cyst can be easily followed up on ultrasound. Completely anechoic lesion, thin imperceptible wall and post-acoustic enhancement. These are the typical features of a simple cyst. Now, with the addition of contrast enhanced ultrasound, the capability of ultrasound has improved quite a bit. So, it's a controversial thing to say that can ultrasound be used as a modality to follow up those post-NIAC 2F lesions. I think with contrast and ultrasound it can be done. The reason is it can show subtle enhancement also. If there is enhancement in the septa, CUS can show that kind of enhancement. So it can be used as an alternative and differentiating Bosniak 2F from 3. That's a critical differentiation to make, and this can be made using CUS. Sometimes this distinction is difficult even on CT or MR, because the ultrasound has better contrast resolution and spatial resolution when you use CUS, so it can differentiate these two things. Other thing is, if sometimes when you do ultrasound and the lesion is hypoechoic and you're not sure whether it's a cystic lesion or a solid lesion, again CUS can help in doing that distinction. This is one example of what I said about upgrading the Bosniak category, where you are trying to find out there is enhancing septa or not in the lesion. This is one of those cases where this is a large cystic lesion and there is a tiny, can't see clearly, but anyway, there is a tiny mural nodule which was present, and we did CT also, dual NG CT also, but we could not figure out whether this lesion was enhancing or not because it was too tiny to measure. So we did contrast and ultrasound. That particular contrast and ultrasound showed that focal area showed enhancement. We could see the bubbles crossing those areas. You can see it very well on contrast and ultrasound. So we upgraded it to 3. So this is another scenario which I talked about, lesion in the upper pole of the kidney, left kidney, hypoechoic. There is not much of post-acoustic enhancement. That way it is not looking like a simple cyst, but it is a difficult lesion to characterize, and that's when we used contrast and ultrasound, which showed definite areas of bubbles within the lesion in the early phase of enhancement. So definitely a solid lesion, not a cystic lesion. These are few unique situations where contrast and ultrasound can be used to solve problems. Coming to the major modality, which is multi-detector CT, and we do this is the routine protocol we follow when we try to characterize a renal lesion. One is non-contrast CT. We don't have a dual NG CT. You have to do a non-contrast CT. The reason is hyperdense lesions cannot be characterized if you do a contrast CT straight away. That's the reason non-contrast is important. It's also good in picking up calcifications and to quantify enhancement if you compare the pre and the post-contrast scans. Corticomedullary phase, which is done around 40 to 50 seconds, it is good to pick up the vascular anatomy the relationship of vessels to the tumor, and it is also good in differentiating tumors from pseudotumors. Pseudotumors will enhance very similar to the cortex if it is present in the cortex, so the enhancement is very similar, and that can be useful in pseudotumors. But the problem is, since the entire kidney is not homogeneously enhancing, you might miss a hypervascular cortical tumors and a hypervascular medullary tumor when you dependent completely on corticomedullary phase. Corticomedullary phase is not good for detection of lesion, it's good for detecting, showing the anatomy of the vessels and the relationship of tumor with the vessels. Nephrographic phase is the phase where you will try to detect the lesion, because this is where the maximum contrast between the homogeneously enhancing parenchyma and the lesion will be there, and that's the reason even small lesions can be picked up on nephrographic phase, which is done between 80 to 120 seconds. Excretory phase, 3 to 5 minutes is the timing of excretory phase, and this is important to show the relationship of a tumor with the PCS, which is an important component when you do a nephrometry, renal nephrometry scores to help the surgeon to operate. So, and the other role of excretory phase is that if you miss out on NCCT, you can, to some extent calculate the washout and say that whether the lesion was solid or not a solid lesion. So that's the other utility of excretory phase of MDCT. This is the routine protocol: non-contrast, corticomedullary, nephrographic, and the excretory phase. And this is how a nephrographic phase look like: homogeneous and homogeneously enhancing parenchyma and any lesion which can be picked up easily on nephrographic phase. Like told about dual lens CT. If you have a dual lens CT, you can probably skip the non-contrast CT totally, because you can generate this virtual non-contrast CT, and it reduces the radiation because cutting down one whole phase when you do a dual lens CT, and it can also give you iodine concentration. So you don't have to depend on the Hounsfield unit to say whether there is enhancement or no enhancement. You can do the iodine concentration measurement if you do a dual lens scan, which can help in figuring out whether the lesion is enhancing or not, and how much is enhancement. And depending on how much is enhancement, you can differentiate Bosniak 3 cyst from papillary carcinoma, or sometimes you can also differentiate a clay cell variety from a papillary cell variety. These are the utility of dual lens scans when you use it. So most of the lesions on focal lesions on a non-contrast scan would be hypodense. There are some things which can be hyperdense on non-contrast CT. These are 3 things which can occur, which can be hyperdense. Hemorrhagic cysts, for obvious reasons, they are hyperdense and they will not enhance in the future post-contrast scans. Lipopenic AMLs, since they are highly cellular, they will also be hyperdense on non-contrast scans, and they also show very good enhancement in the post-contrast scan. RCC, especially the papillary cell variety, can show hyperdensity on non-contrast scan of a CCT, non-contrast scan on CT. Coming to MR, which is the problem-solving modality here, this is a routine sequence we follow: T1 in and post phase and T1 fat sat. T1 fat sat is important here because you are trying to estimate or detect the macroscopic fat in lesions like AML. So this particular sequence of T1 fat sat is important. T1 in and post phase is also important because that is used to characterize clear cell sarcoma, clear cell variety of RCC and AML. Both of them can show a drop in signal in the opposed phase. Other sequences are T2 fat sat, axial and coronal, dynamic contrast scan, diffusion weighted imaging, MR urography. The other sequences we acquire as a routine part of MR acquisition. These are the useful scenarios where MR can help you even after doing a CT, especially where you feel that the lesion was hyperdense and you are not able to make sure whether there is enhancement or not. MR can characterize it much better than CT. Other area where it is better than CT is that depiction of septations and mural nodules, and the enhancement of those is one area where MR can be better than CT. And pseudolutions, when you have pseudolution, especially in patients with CKD, it's difficult to give contrast in those patients, and that's when diffusion weighted imaging on MR is very good, because diffusion restriction will not be there in pseudolutions, whereas it will be there in true tumors. Again, most of the lesions are T1 hypointense and T2 hyperintense, but there are lesions which can be the other way around. Like T1 hyperintense lesions can be hemorrhagic cyst. AML with macroscopic fat within the typical AMLs will have this hyperintensity on T1 weighted sequence, and RCC, especially the clear cell type, will have intravoxel fat, and sometimes it can show hemorrhage. So those things will be hyperintense on T1. T2, most of the lesions we expect that those to be hyperintense, but some lesions can be hypointense. This is important to know. Hemorrhagic cyst will be hypointense. It can be hypointense on T2 weighted sequences, but there will not be any contrast enhancement in those lesions. Papillary RCCs are typically hypovascular lesions, and they are typically T2 hypointense. They don't enhance much, and they are T2 hypointense. This is one characteristic feature of papillary renal cell carcinoma. Lipopenic AML is difficult to characterize, but then they are also hypointense on T2 weighted sequences, but they enhance very well in the post-contrast sequences. So these are few examples of MR where here there are multiple cysts. Here is a ball-like lesion in the left kidney posterior cortex, and it's showing some kind of signal drop on the apostrophe image, which means that there is some microscopic fat within, which is characteristic of clay cell variety of RCC. We can figure out that just based on MR. And this is another case where there is a large lesion in the on CT, and on MR we can see that that lesion had multiple areas of bleed, and because of which it is T1 hyperintense. This is one interesting case which presented to our hospital, and this patient had a CT, and this was the lesion which looked like a mass in the right kidney upper pole. There was no non-contrast CT. We were not sure whether it is bleed or hyperdensity or enhancement. So so that we repeated the MR in our institute, and it showed that there is reduction in size of the lesion. First thing, there is reduction, and there is T1 hyperintensity, T2 hyperintensity, and there is no enhancement, which means that it is probably a clot or a bleed which has happened in the cyst, which reduced in size over a period of time. So these are areas where MR can help to solve problems when CT cannot. So I'll probably, in the interest of time, I'll skip these things just to highlight that these are the renal lesions. You can probably click it, and just to show that clay cell variety will have higher single intensity on T2, papillary will have low intensity on T2, and chromophobe and oncocytoma will have no, it's very difficult to differentiate these two things. Classical AML, lipid peripheral MLI, we have talked about it earlier. So other important concept when you are dealing with renal lesion is to figure out the morphology of the lesion, whether it is a ball type lesion or a bean type lesion. Ball type lesions is nothing but there is an extra soft tissue which is sitting over the parenchyma, which is causing contour abnormality. That is when we call it as ball type lesion. Bean type lesion is nothing but when it is infiltrative, centered in the PCS, it is infiltrating the tissue. It is not creating additional volume or anything. It can probably enlarge the kidney, but it will not generally change the contour of the kidney. The reniform shape will be maintained in patients with in lesions with bean morphology. So this is important to know, because this distinction is important to differentiate RCC from TCCs, because both are solid lesions, but the way they appear on imaging, they present is different. So most of the ball type lesions are RCCs, and most of the bean type lesions are TCCs. For example, this is a ball type lesion. There is definite contour abnormality here, which is bulging. There is bulge in the posterior cortex, and this is definitely a ball type lesion, issue of RCC. And this is here, you can see that the reniform shape of the kidney itself is maintained, but still there is a focal lesion, which is nothing but TCC, which is having that bean shape morphology. So this is again ball and bean type morphology. The prototype lesion for ball type morphology is RCC. Obviously, there are other lesions which can also present like this. Even cysts and abscess can present like ball-shaped morphology. The prototype lesion for bean morphology is TCC, and even there are lesions, type of lesions in RCC which can present like bean morphology, but there are exceptions. Those are exceptions, but these are the prototype lesions of ball and bean. This particular thing is important to know, that differentiates focal lesion, whether it is RCC or TCC. So this is a few examples of RCC, typical RCCs where there is ball type lesion arising from the right kidney upper pole, hypervascular lesion, multiple vessels. You can see that in the corticomedullary phase, and is also invading into the right renal vein and reaching up to the infrahepatic IVC, which is probably better seen on the portal venous phase or the nephrographic phase. There are multiple lesions in the lung, which is characteristic. I mean, renal lesions, RCCs metastasize to lung, and the characteristic feature of renal cancer metastasis to bone is this kind of expansile lytic lesions. Most of the cancers will metastasize to bone. They will not cause this expansion of the cortex, but RCCs and thyroid cancers are two exceptions where it can cause expansion of the bone, and sometimes they can mimic like a primary bone tumor. So this is one characteristic feature of RCC. And yeah, here if you look at this, this looks like the reniform shape is maintained, the lesion is seen within the PCS, but the enhancement is heterogeneous, and the one key feature is that the tumor is infiltrating into the right kidney. Although there is no ball type morphology, it looks like a bean type morphology, but the enhancement is very good, heterogeneous, and the extension into the vessel is one thing which will definitely go in favor of RCCs. So morphology as well as the way the tumor is invading is also important. So just a couple of slides to just show the differences between the clear cell variety and the non-clear cell variety of RCC. Clear cell variety will show heterogeneous enhancement and intense enhancement in the early phase, whereas papillary will not show that kind of enhancement. That's a major difference between these two things. This is typical of clear cell type of RCC, whereas this is typical of papillary type of RCC. Another example of papillary RCC where it may look like a complicated cyst or hyperdense cyst, the visibility, it's very difficult to figure out whether it is enhancing or not, but this is how papillary RCCs behave. That's the reason it's important to measure the Hounsfield units between the non-contrast and the post-contrast, and to show there is some kind of enhancement, although it is less, and it is important to show the enhancement. This is another case scenario where we found it difficult to show that enhancement, and this is a lesion on ultrasound, focal lesion which is hyperechoic. On MR T2 weighted image, there is hypo-intense, lesion is completely hypo-intense. Better seen on T2 weighted axial images. The diffusion restriction is also there. ADC is dark, so there is definite diffusion restriction. And if you look at the post-contrast dynamic phase, there is hardly any enhancement visibly. But if you look at the ROI statistics, if you put ROI there is definite increase in enhancement. There is multiple, definite more than 15% enhancement definitely that is there in that particular lesion. So this is typical of papillary RCC. That's the reason papillary RCCs can mimic a lot. It can mimic a cyst a lot, but these are the things which can be done to figure out. I think I'll skip these slides. Just a couple of words on the nephrometry. Nephrometry is important when the surgeon is contemplating to do a partial nephrectomy. When he is trying to do a complete radical nephrectomy, nephrometry scoring is not so relevant. But when the surgeon is trying to do a partial resection or a partial nephrectomy, that is where the nephrometry scoring is important. This will give an idea how difficult will the surgery be, and what are the complications it can be expected. So higher, it's there in the literature. The scoring is based on 4 or 5 things: the size of the lesion, endophytic, exophytic nature of the lesion, nearness to the PCS, the location, whether it is anterior or posterior, or it is located in the polar region or in the interpolar region. This is how this nephrometry scoring is calculated, and based on this you will arrive at a score. Higher the score, difficult will be the surgery. So this is something which the surgeon would want from you, that when he is trying to do a partial nephrectomy, how difficult will it be, and that will be based on this particular scoring. So this is a typical score of this particular lesion, that this particular lesion had a renal nephrometry score of 6x. So this is okay. I'll skip this Bosniak thing, and I just wanted to conclude here because of the lack of time. It's important to image these focal lesions rationally, choose the right modality. What you have, ultrasound is a screening modality, but CT is the modality of choice, and MR is a modality where you can use it as a problem solving thing. And the characterization is important, especially benign versus malignant. If you are benign, cyst versus solid. If it is solid, then it is important to characterize whether it is benign or a malignant lesion. It is not very important to characterize the subtypes of RCC just based on imaging. If you are able to, it is good, but the important distinction is to say whether it is benign or malignant if you are dealing with a solid lesion. And nephrometry scoring is important because that will give a surgeon an insight of how difficult will be the surgery. So that's important to write in your report. Apart from the staging and a TNM thing, nephrometry score is also important to mention in your report. Thank you so much.
Thank you very much, Dr. Deva. That was a fantastic talk. And Deva here. Here. Yeah. Okay. So, when will you give importance to the lung nodules in a patient with RCC?
Yeah, so it's a difficult thing because anything which is more than 5 mm we consider it as significant, and especially if it is not calcified, if there is no speculation, there is no satellite nodules, which is very characteristic for anything which is not looking like a granuloma, we give importance to those.
Because in some institution, if the lung nodules are 2 or 3, they proceed with the nephrectomy, and so the treatment for the RCC.
Okay.
Then, yeah.
Yeah. Okay. Oh, yeah. So yeah, if there are, yeah, I think our urologists also follow this. If there are, it can be tackled with TKIs and other drugs later on. Yeah, I think that's an institutional based practice.
Thank you, Dr.
Any queries from the audience?
Thank you, sir, for those crucial and illuminating pointers on the pivotal role of imaging in renal cell carcinoma.